Thank you and good afternoon. So my talk is entitled Preeclampsia, the Evolving Role of the Anesthesiologist. I have no disclosures. The objectives are to compare current practice with best evidence to identify areas for improvement, to discuss the role of the anesthesiologist in the management of preeclampsia, and to understand how to safely manage the airway in a parturient with preeclampsia. So the data on this slide is taken from a study that was carried out in Australia from the year 2000 to 2008. It involved almost 700,000 deliveries, 23,000 of which had preeclampsia. And their incidence of preeclampsia in all singleton pregnancies was 3.3. This had shown a decline in the number over the 9-year period from 4.6 to 2.3. However, their incidence of eclampsia in the same study in women who'd had preeclampsia actually rose from 2.3 to 4.2, giving an incidence over the 9-year period of 2.6. So the decrease in the preeclampsia did not equate with a decrease in eclampsia. And eclampsia was found to be more prevalent in younger parturients and patients who were having their first baby as opposed to multiples. So the numbers of eclampsia patients in relation to birth numbers, you can see the data here. The UK, US and Australia vary from 2.7 to 8.6 per 10,000 births. And you might ask why in these developed countries there's such a difference over the same time period. And the reasons could be for several reasons, one of which is the definition. The definition does alter between countries. And also guidelines. Each country has its own guideline, and guidelines do vary. So that could account for the differences. Another difference is coding. Now you may have experienced this in your own practice. Coding can be a nightmare if people don't do it right. And who knows what the true instance of diseases and syndromes are if the coding isn't right. So this could explain some discrepancies in the numbers. Now it's not a surprise to see that developing countries, the instance ranged from 16 to 69, and that could be explained by different healthcare resources and accessibility of these healthcare resources. So the relative risk of eclampsia in a preeclamptic woman comparing 2008 to 2000 in this Australian study was 1.9. The relative risk of women with preeclampsia or eclampsia dying within 12 months of delivery compared with the normal intensive cohort was 5.1. Now these women who died within 12 months of delivery had experienced preeclampsia. They didn't die as a result of preeclampsia, not all of them anyway, but they had preeclampsia during their pregnancy. So in terms of the neonatal mortality, so we talk about the mother's mortality, but how about the infant, the neonate? Now this can be caused by two main reasons. A, because of the preeclampsia. So preeclampsia causes IUGR in the baby. And also a lot of these patients do have preterm deliveries. So the baby is exposed to two main risk factors, the preeclamptic effects and the preterm delivery effects. And you can see quite a range here per 1,000 births, from 7.9 in a normal intensive cohort to 10.7 and 22.3 in the group of patients who had eclampsia. Now the occurrence of seizures. So the three main time periods, obviously before the baby is delivered, during delivery and postpartum. Now when do the seizures occur? So you can see the majority of seizures occur actually during labour. And it was a surprise to me that 26.3% of seizures occurred, such a large, almost a quarter, well more than a quarter, occurred in the postpartum period. So we quite often think to ourselves, oh, the patient's got preeclampsia, the placenta's in situ, once the placenta's being delivered, the woman's going to be cured, or hopefully she's going to be cured because the placenta is contributing to the preeclampsia. But that's not always the case. There was 53% of these patients actually had their seizure on the day of delivery, which takes into account the 44.1% and a small proportion of the postpartum patients if they had their seizure postpartum, say 2 or 3 hours after delivery. Now, the postpartum data, you can see the postpartum median day of the patient having a seizure was day 4, which that was quite a surprise to me, actually day 4. They could have had the baby, things that start to settle down, and then they have a seizure. And the range was actually days 1 to 55. So imagine having a patient having a seizure 55 days after delivery. Not many of us would actually, if we're honest, think that it's related to the preeclampsia, but it can be. So this bar chart shows pregnancy-related mortality in the US over 3 time periods from 1987 to 2005. And you can see hypertensive disorders, they account for the second most, the sum total, the second most common reason of maternal mortality. However, there has been improvement over the 3 time periods. And over the last time period from 1998 until 2005, in the US, hypertensive disorders was the 4th leading cause of maternal mortality. And you can see in 10th place is anesthesia, and again, there is evidence of improvement, but there's always room for improvement. Every single patient we deal with, we should always be trying to improve our care. Now, this data, we've mentioned several times at this conference about the UK data, and you can tell from my accent that I'm not from here, that I'm from the UK, which may make me biased towards UK data, but the truth is that UK data in maternal mortality has been collected in such a robust way, going back to the mid-80s, that it's very reliable. And although the US data is still reliable, it's questionable whether it is as reliable as this data. Although I have to be careful what I say now because of the score report from SOAP. So you can see from the preeclampsia and eclampsia data, this has been reported together. Some reports report the preeclampsia data and the eclampsia data separate, but this is all together. And you can see back in the mid-80s, the mortality rate per 100,000 maternities was almost 1.2. And then in the early 2000s, it decreased to 0.7. But in the mid-2000s, it started to rise again to 0.85, 0.83. However, the last report, 2009 to 2011, it was 0.42. And you might wonder why that is. And one of the explanations could be the way we treat it. We understand that we need to be more aggressive in terms of the instance of PPH. Our management of PPH has improved, and now our management of preeclampsia and eclampsia is starting to improve. And that could be for several reasons, one of which could be guidelines and education to try and establish that we do need to be serious about these women, about the disease, treat hypertension, give the patients magnesium, try and avoid them progressing to having eclampsia. So I mentioned guidelines. So all these bodies here, 3 of which are from the US, 3 of which are from the UK, all have guidelines or recommendations in terms of management of patients with preeclampsia and eclampsia. And it's important as OB anesthesiologists that we are aware of not only our own guidelines, such as the ASA guidelines, SOAP guidelines, but also specific OB guidelines, because it's us that are treating the patients on L&D with the obstetricians. And although we have our own specialty, we do work as a team in L&D. So it's important that we're aware of their guidelines, they're aware of our guidelines to a certain extent as well. So in terms of the classification of preeclampsia, if we have guidelines, it means we're all starting on the same page. We all understand the terminology, we all use the same terminology and can treat the patients in the same way, same guidelines. So in terms of the definition, so there's 4 main classifications. There's the preeclampsia and eclampsia, which we're going to talk about in the next few slides. There's chronic hypertension, which is when a patient has a history of hypertension pre-pregnancy of any etiology. There's chronic hypertension with superimposed pre, and that's self-explanatory from the words you can read now. And also gestational hypertension, which is raised blood pressure after 20 weeks, but without proteinuria and without any systemic findings. So again, we all need to be on the same page in terms of the language we use in L&D, so we're all aware of how to treat these patients. And the 2 underlined preeclampsia, whether it's superimposed or not, they're the ones we have to watch out for. So the diagnostic criteria for preeclampsia. So in 2013, there was a paper published by ACOG, which defined the criteria, and it did change from the previous publication. So any patient with hypertension greater than 160 and 110, after having that level of blood pressure for 15 minutes, can be diagnosed with preeclampsia if they have proteinuria and or systemic findings. So it used to be that patients had to have proteinuria for certain guidelines for them to be diagnosed with preeclampsia, but now they don't always need to have proteinuria, but then they would have to have one of these 1 to 5 systemic findings. The other thing to bear in mind is patients don't always need to be up at a level of 160 or 110. They could be at greater than 140 or 90, but over a 4-hour period. So it's important to know these guidelines so that we can treat the patients accordingly. So the role of the anesthesiologist in the management of preeclamptic patients. So how can we help? So there's lots of topics related to preeclampsia that we could talk about, but I don't have time to discuss them all in 25 minutes. So I'm going to talk about blood pressure control. But all these 5 things are important to be working as a team on labour and delivery to accomplish all these things for the benefit of the mother and for the baby. So this year, ACOG published a guideline or committee opinion about treatment for acute onset severe hypertension. And this was an updated document from 2011. And the main difference between this document and the document from 2011 was the addition of nifedipine as a first-line antihypertensive. So it's important that you are aware of these guidelines, and it's only 4 pages long, so you can easily read it. And there's 3 main tables that discuss the medication. So just to mention briefly, so this is an algorithm that I put together in 2012. At Stanford, I'm involved with simulation, and we did a study in 2012 looking at having a patient coming in with severe preeclampsia, severe preeclampsia and having an eclamptic seizure. And we used this algorithm to have in place for the drill. But after the drill, we continued to have it in clinical practice, and we now have it in every L&D room and in each OR. And the idea of this is that we all need to know these guidelines, but in an emergency, or not everyone likes to read papers, even if it's just a 4-page document. But having the information on a cognitive aid like this, an algorithm, it can be easily interpreted and referred to quickly. So the idea is there's a lot of information that's difficult for you to read on here, but it describes how to give the drugs and which drugs to give in terms of preeclampsia. So just going to go briefly over the drugs. So there's 3 main first-line antihypertensives. The first one I'm going to talk about is labetalol, and they're increasing doses of 20, 40, 80, and then hydralazine 10 milligrams. And we need to wait 10 minutes in between each dose of labetalol because the peak effect of labetalol can take up to 5 minutes. So waiting 10 minutes just gives it the chance to actually work before giving a stronger dose, a higher dose. If you get to hydralazine and the patient's still not under control, then we need to be discussing second-line antihypertensives and discussing more serious treatment options and ICU, anesthesiology involvement, ICU, MFM, things like that. So the second drug to talk about, the second first-line antihypertensive is hydralazine. And here we start off with 5 or 10, then progress to 10. Now with hydralazine, the peak effect can be up to 15 minutes. So we wait 20 minutes between each hydralazine dose and then move on to labetalol. Now this is a new thing that's been added this year, so nifedipine, and it's an oral medication. So we give it 10 milligrams and then 20 milligrams and then another 20 milligrams if necessary, and then labetalol. And yesterday on one of the slides, it was mentioned about, you might think it's a bit strange to give a PO medication in an emergency, but there is evidence that nifedipine orally, not sublingually, so the patient's not to bite the capsule. If they do, they can get a profound hypotensive effect. So they need to swallow the capsule, but the absorption is very fast, and the effect is very fast. And there is data to suggest that this effect is faster than giving IV labetalol. Now, second-line antihypertensives. So ACOG mentioned giving labetalol infusion or nicardipine infusion. Now, they don't specify the dose, so I've just put these doses in as what I would recommend, but you can titrate the medication or choose your own starting dose, whatever you think is appropriate for the patient you're treating. In extreme emergencies, we're going to use sodium nitroprusside. And again, if we need to give second-line antihypertensives, the patient's going to be in ICU. Now, this is the other side of the algorithm, of the preeclamptic algorithm. Now we're talking about eclampsia. And this is just a one-page, double-sided algorithm that we have in L&D as a quick reference. And it talks about the airway breathing management of the patient, talks about seizure control and seizure prophylaxis, and also about monitoring the baby during the seizure. And it's just quite useful to have this available and accessible whenever nurses or MDs or anyone on L&D wants to refer to it, rather than having to read through a paper and text. So something else we have on L&D at Stanford is an emergency drug box. And this was something that me and Alex Butwick had experienced in the UK, and we introduced it into Stanford, and it's proven to be very useful. Now what it is it's a box full of drugs, as described, and it's only to be used in severe preeclamptic patients or eclamptic patients. And the idea is, now that we all have electronic drug storage, if a patient comes in and you need to access drugs very quickly, there may be a problem accessing the electronic version. We use a fingerprint, sometimes your fingerprint doesn't work, then the pharmacy have to sometimes approve the medication. But you want to get your hands on those drugs and give the patient the drugs as soon as you can. So we have this box in the L&D OR hallway next to the other emergency equipment. So it's a little bit difficult to see on this slide, but it's next to the code cart, next to the PPH cart, next to the difficult airway cart. We have a red box that has intralipid for last, and then we have this green and black box for severe preeclampsia and eclampsia. Initially we just labelled it as the eclamptic box, but now we label it as a severe preeclampsia, eclampsia emergency drug box. Now the contents. So this was devised by me and some of the OB team on L&D, and it's got drugs in that we want to access quickly. Now two of them, Esmol and propofol, as you can see in bold, it says by anesthesiologist only, and the nurses, so anybody can grab this box, a nurse, an MD, a tech, anyone. If you need the box quick, you just ask for it and someone brings it to you. So the nurses know they're not to administer Esmol or propofol. We've given them very strict instructions. So we need to update this from the new guidelines, and also the algorithms from the new guidelines, since nifedipine is now being added. But it's just useful. I'd recommend you to have this on your L&D if you don't have this already, because several times we've had to use it. And every time we use it, we send it around to pharmacy and they restock it for us. It's not something that we just use to, if someone needs hydralazine, for example, but it's not a true emergency, we don't just open the box. It's got a locked tag on it, just for emergency use. Now, the reason we have propofol in it is not to induce anesthesia to intubate the patient. It's if the patient has an eclamptic seizure and the seizure is not breaking, we'll give them 3 or 4 mils, which is 30 or 40 milligrams of propofol, to try and break the seizure. You can also use benzodiazepines, but we weren't allowed to have them in the box, obviously, because they're controlled drugs, and this box is just sitting there and someone could walk off with it. So it's recommended just to have this just for the patient's safety, to treat the hypertension as quickly and easily as you can. And we also have supplies in terms of syringes and blood pump tubing. Alaris pump tubing. So now I want to talk about how to safely manage the airway in a parturient with preeclampsia. Now, can you raise your hand? This is not a trick question, and I want you to be honest. So a start C-section needs to be done in a non-preeclamptic patient, and we quite often, we usually just use propofol and sucks. We tend not to use narcotics or any other medication. If you had a patient coming in for a C-section needing general anesthesia, hands up if you would use something different or in addition to propofol and sucks, or would you just maintain propofol and sucks? So hands up if you'd use something else in addition or different. Okay, hands down. Who would use propofol and sucks and nothing else? Okay. So the reason why I wanted to talk about this is because I think it's very, very important. And lots of things we've talked about this conference are important, but this is one of those things. So if you're doing a general anaesthetic for a patient with preeclampsia, it's important that we do take steps to modify the drugs we use. The reason why we do this is that these patients are at increased risk of having a stroke if we don't try and obtund their response to laryngoscopy. Preeclamptic patients have a hyperstimulated larynx, and they're going to have a massive sympathetic outflow if we don't obtund that. Even with a straightforward grade 1 fast, smooth intubation, the stimulus on the patient's larynx can be massive and cause massive rise in blood pressure and heart rate, and can ultimately cause the patient to have a stroke. So any of these patients, preeclampsia, eclampsia, any symptoms or signs of raised intracranial pressure, we want to think before we actually do anything to this patient. Now, hopefully, the incidence of general anesthesia for preeclamptic patients is very low, because ideally we want to use regional anesthesia. So this can be quite a stressful situation, because people do get stressed about using general anesthesia in OB, but more so if it's now in a preeclamptic patient. So that's why I wanted to talk about this, just so you can have time to think about it before you actually meet a patient who needs general anesthetic with preeclampsia. So what we want to avoid, so on the left you can see unmodified technique, on the right is a modified technique. And this is not true data, I just made these graphs up. So you can see the blue line, this is just to make a point. So the blue line is systolic blood pressure. So they're starting off at 120. So this patient came in at 160, they've had treatment, and now they're at 120. Now you could say that's an okay blood pressure, but this patient still has preeclampsia, but now it's treated. So whether it's treated or not treated, we need to take modifications. So we give the patient some propofol and sucks. Then we intubate the patient, smooth, grade 1, slick intubation, and despite doing a good job, the blood pressure rises to 160, 180. Now we don't know, there's no randomized controlled trials looking at what level of blood pressure is needed for a patient to have a stroke. And I'm not going to do that kind of study, and neither are you. So we don't know whether the patient's going to have a stroke at 160, 180, 250, 260, 270, and how long do they need to be at that level of blood pressure? 1 second, 10 seconds, a minute? We don't want to put those patients at risk. So even 1 second at 160 could be too much for that patient and cause a stroke. So we want to use drugs that's going to modify our technique and modify the cardiovascular changes that occur at intubation and have a nice smooth induction vital signs. Because we want to avoid this. So data from the UK looking at deaths from preeclampsia and eclampsia. The 3 main reasons patients can die: from cerebral causes, hepatic causes, or pulmonary. And the majority of patients die because of intracerebral hemorrhage. Now, these reports, the 2003 to 2005 report does mention that 2 patients out of the 9 patients here did have intubation, and that was what was thought of that caused their stroke that was identified at post-mortem. The 2006 and 2008 data doesn't specify if these patients had intubation, but 9 patients died of intracranial hemorrhage. The latest report from 2009, 10, 11 identifies 10 patients who died of preeclampsia or eclampsia combined together. But the last final report shows their data different to the previous reports, and it's not as detailed in terms of the data for preeclampsia and eclampsia. Now, looking at studies, which drugs do we want to use to try and obtain this response? So there was a study published in 2007 which looked at 4 groups: a control group, a group with esmolol, a group with lidocaine, and a group with fentanyl. Now, this is not in an OB population. This was ASA 1 and 2 adults having general surgical cases. They had 120 patients, and they looked at the patient's RPP, which is the rate pressure product, which is the heart rate times the systolic blood pressure. And what they found was that esmolol 1.5 milligrams per kilogram at induction gave the most favourable cardiovascular response to intubation. A study published in IJO in 2002 looked at pregnant patients with pregnancy-induced hypertension, 80 patients, and they were randomized into these 4 groups. Now, the 3 groups highlighted in orange showed all favourable results in terms of cardiovascular changes, but the authors chose Esmolol 1 milligram plus lidocaine as their most favourite or recommended drugs to use. The reason why they chose this was because it was the lowest dose of Esmolol, and they had concern that Esmolol may cause bradycardia in the babies, although in their 80 patients there was no adverse effects on the fetus. So in terms of narcotics, we're going to use narcotics. You may not. So this study, published in 2012, compared fentanyl and remifentanil proved to be more favourable than fentanyl. But with this study, the remifentanil, they used a concentration of a rate of 0.5 mics per kilogram per minute, started 5 minutes before induction. And the fentanyl group had 50 mics of fentanyl as a bolus. And I don't think 50 mics of fentanyl is a very big dose. I'm not surprised it didn't have dramatic changes in terms of control. So what are you going to use? So we're going to, moving down to induction agent, we're going to induce the patient with propofol. We're going to use succinylcholine unless it's contraindicated. We're going to maintain the anesthesia with oxygen, plus or minus nitrous, plus the volatile agent of your choice. Now, in terms of modification, in my practice, I would choose to use Esmolol, 1 to 2 milligrams per kilogram, and remifentanil, 1 mic per kilogram bolus. Depending on the patient, this is not set in stone. Obviously, every patient we treat, we need to alter things potentially. And the reason it's important that you think about this before you're actually in the situation. And some things can vary as to what you do choose, such as remifentanil. If it's a true emergency and we have to give the medication quickly, it can be problematic given remifentanil in terms of dilution, getting the dilution right, you're thinking about other things. So if you can reliably dilute the remifentanil and administer it safely, I'd recommend you do that. Well, that's what I recommend in my practice. And Esmolol bolus. Now, the importance of these drugs is to get the timing right, because there's no point giving a drug if you're going to not benefit from the effects of it. So in terms of, if you've got a patient who came in with a blood pressure of 220 and they need a stat section for fetal bradycardia, you have to think about when is safe to induce anesthesia for this patient. And I would recommend a blood pressure starting at 220 is not a safe level to be inducing anesthesia. And the CMAC guidelines from the UK do recommend that time is taken by the anesthesiologist to control maternal cardiovascular numbers before inducing anesthesia for the benefit of the mother and for the baby. Now, it can be a little bit harsh, what I'm going to say now, but it's reality that if you've got a fetal bradycardia, but you've got a maternal blood pressure at 220, 240, your priority is the mum. Your priority is the mum's brain. You don't want to induce anesthesia and then cause a stroke, kill the mum, and ultimately potentially cause damage to the baby. So our prime concern is to control, as much as you can, the maternal cardiovascular status. Now you might ask, how long are we going to wait? We're not going to wait hours and hours, obviously, if the fetal bradycardia is at 40 or 50. But you need to, in your head, think of a number, approximately, that you want to lower the maternal blood pressure to. And there's no literature to suggest it has to be 160, 180, 190, but you have to think yourself what is safe for this patient. So I had a patient that came in once at 240, and we treated the patient with Esmolol boluses, 2 boluses, and brought the patient's blood pressure down to 180. So I had in my mind that I wanted the blood pressure to be 180, and then I was relatively happy to induce anesthesia. It wasn't ideal, but in terms of we don't want to cause too much damage or potential damage to the baby. And that's something you've got to think about. What level are you happy to induce this patient? The other thing to think about is patients without neuraxial narcotics. We give them the anesthetic, we get the tube, we give them the drugs, Esmolol, remifentanil, propofol, sux, grade 1 intubation. Now, most stat C-sections, as soon as you put the tube in, confirm end-tidal CO2, we tell the obstetrician to start. But in these patients, you just need to take a few extra seconds just to check the blood pressure post-intubation. Because you've done a great job, you've given the drugs on the right time, the blood pressure didn't rise on laryngoscopy, and now the patient's going to have a surgical incision, and they may not have any narcotics on board. So they may have a second spike of the blood pressure. So before you tell the obstetrician to start, I would glance around the blood pressure monitor, just check it's still in a controlled level. Because if it isn't, if you've got your timing wrong, and it's now shot up to 220, you want to control that blood pressure before skin incision. So just one last slide. This was a review published in 2014 by Melissa Plant and Barbara Scavone, and they review lots of different drugs that potentially could be used to induce anesthesia for patients with preeclampsia. And the conclusions was that it's a combination of drugs that can lead to optimal cardiovascular stability. And these authors would recommend esmolol 1.5 milligrams per kilogram or nitroglycerine 2 mics per kilogram combined with propofol. And the key is for you to decide yourself, after reviewing literature, what you feel safe to administer. And one just final thing to say about this is we shouldn't be using a drug for the first time in an emergency that is critical about timing. So if you're going to start to use esmolol or other drugs and you've not used them before, it's a good idea to become familiar with them in an elective setting rather than in an emergency, acute, very important situation. Thank you. If you have any questions, I'll answer questions at the end, or you can email me.